cross, that is to say, that straddle jurisdictional boundaries and better harness the strengths of states and center, technology, finance, logistics, supply chain, transport, manufacturing, military, paramilitaries, border control, police, private sector, industry, basically everyone, all of society, all of government, all of nation approach. Thirdly, health, both physical and mental, plays a very important role on how communities deal with its prolific effects. What tools and what support can the government offer? And here, particularly in the not just the urban areas, but the rural areas, where millions of people have actually gone, and who knows whether they've taken with them the coronavirus. And what exactly would we do if there is a huge health crisis in the rural areas? How do we look at providing them the facilities? Because currently it seems the focus is very urban centric. We are talking about cities. We are talking about people like you and me who have jobs, who have security, who have some finances to buy medication. But will the needs of the rural population ultimately be met? If so, how? Next, healthcare workers and infrastructure are the front line in this pandemic. And very unfortunately, we have seen images of how they have been maligned, they have been ostracized, in some cases, even attacked by members of society who ought to be with folded hands, thanking them and saluting them for their selfless service to our society. And so, how do we prevent these attacks? What kind of education is required? Who should do this? How do we protect them better? Of course, laws have come in now. Lastly, is there scope to promote not just yoga, but also Ayush, as in Ayurveda, Unani medicine, or Siddha, or homeopathic medicine in regard to the coronavirus? So, with these few words, may I now turn to the first speaker, the very eminent Dr. Devi Shetty. The floor is yours. If you can, please, about 15 minutes. Over to you.
Thank you. Thank you so much for the opportunity. I hope I'm audible.
Yes, indeed you are.
Okay. The first thing, we are today dealing with the disease which is only 3 months old. So there are no experts, there is no precedence, there is no protocol, there is no treatment. So essentially, we are caught out for the first time without really knowing how to address this unknown enemy. Now, I would like to present my experiences of having deeply involved in this process, mainly as a senior doctor of the country, trying to figure out how do we come out of this current situation. Now, these are all disjointed thought processes, not a very structured presentation. So please forgive me for the disjointed observations. My first observation is that lockdown for 21 days, which got extended, in my opinion, will or should bring down the mortality following COVID-19 by at least 50%. Half the battle is already won by the government effort to go for a lockdown and implement it. It's not just the question of government's intent of a lockdown. If you follow the Google social activity map, they map all the social activity happening outside homes of every city. In India, in the US, the social activity, social interaction came down by only about 15-20%. In India, during the lockdown, it came down by 75%. That means it is very, very effectively implemented. Now, another question is it the last time we are going to see this type of a pandemic? I am afraid it is not going to be the last time, I feel it will become a more or less regular event in the future, because I feel this one epidemic has reduced the value of atomic bomb by 90%. It is pointless now any country trying to develop an atomic bomb as a weapon for hurting the enemy or a weapon to protect themselves. All you need to do is to have few scientists who can create a man-made virus which can create havoc. The next question is, how does the lockdown help? Will it prevent the disease? No. Lockdown may not even reduce the number of people who are going to be infected with the virus over a period of 1 or 2 years. But what lockdown does is it staggers the number of people who present in the ICU in a manner that the entire health system doesn't get overwhelmed. If you recollect what happened in Italy, in a town called Lombardy, the entire Lombardy region had 750 ICU beds with great difficulty, and they were presented with 5,000 patients. So essentially, half the people were not killed by the virus. They were killed by the lack of medical care for the weak and old. Because even in the first world countries, when you are landed in a situation wherein there is a 80-year-old man with the multiple problem on a ventilator, and there is another 30-year-old man who will need a ventilator, and that is the only ventilator available, they pull out the tube from an elderly person to save the life of a young person, which is fair. But all this happened mainly because of the shortage and the overwhelming of the health system. And lockdown, what it does is to stagger the presentation of all these people. Now, unfortunately, if you look at from a humanitarian angle of COVID-19 in country like India, it is the rich people, it's affluent people, it's educated people who brought the disease to the country, and it is the poor people who are bearing the brunt of the disease. The uh, the uh, the Another interesting observation is India was always trying to project the private hospitals and the infrastructure and the expertise and the knowledge as the forerunner of the country's healthcare. But what COVID-19 brought to the forefront are the public hospitals. Today, there are hardly any COVID-19 patients are treated in a private hospital. They're all treated in a public hospital. And by the grace of God, they have done a good job so far. But the issue is, God forbid, if the number increased, say 3 times or 4 times, can the public hospital deliver? If the incidence of people needing ICU care may not be to the level of US and Europe, even if it is 10% or 20% of what happened in US and Europe, can our public hospital deal with that? Sorry, they can't. Mainly because today 80% is the shortage of medical specialists in public hospitals across the country. And this tells all of us that never ignore the public hospital. Why public hospitals are at the forefront? Mainly because COVID ICU care can be managed only by young doctors with great skill. COVID ICU is not a safe place for 50-year-old, 60-year-old intensivists and anesthetists. Unfortunately, what has happened in our country is everyone for 1 month debating about the ventilator. That country has less than 40,000 ventilator. It is a big risk. So we need to make more ventilators. And we are blessed with dynamic industry and entrepreneurs and intellectuals, startups. They all jumped into the foray and they started making ventilators. But you need a person called anesthesiologist who's going to connect the patient, COVID patient, to the ventilator. And in the whole country, there are not more than 40,000 anesthesiologists. And my assessment is that at least half of them are more than 40 and more than 50 and 60. I don't think they will come anywhere near a COVID patient. So that means you are left with the 20,000 anesthetists who are going to intubate patient with COVID disease. Because putting a endotracheal tube into the lungs of a patient in florid failure in a patient with COVID requires phenomenal skill. Skill is not to save the patient's life. Skill is to save the doctor's own life. So it is not a very easy task. So that brings on the question is that God has been kind to us. If, God forbid, if it goes out of hand, are our public hospital, private hospital are in a position to handle this? No, we need to address this issue of shortage of skilled manpower significantly for us to be in a position to handle this kind of epidemic in the future. Which is the ideal hospital to deal with COVID-19? No matter which private hospital with all the infrastructure, only the hospitals which is an academic institution can take care of COVID patients. When I say academic institution, a hospital with medical college, which has a huge number of resident doctors who are undergoing training program, and there are enough senior faculty who can guide them. If you do not have the combination of academic, the faculty, as well as the large number of postgraduate students in your hospital, believe me, no matter how much infrastructure you have, you will not be able to handle those patients. Now, next question is, why COVID ICU requires that kind of a skilled manpower and why there is a acute shortage? Mainly because to protect themselves, doctors and nurses should be wearing PPEs. You would have seen in all these gowns, 3-4 layers. It is very difficult for anyone to work for more than 4 to 6 hours wearing the PPE, because we generally switch off the air conditioning system. So without air conditioning system in this summer heat, for them to manage, we have seen some of our nurses even collapse wearing the PPEs within few hours. So the interesting thing is the innovations what has happened in a matter of few months. First thing is looking at the situation in Italy, where a general hospital allotted 20 bed, 30 bed for COVID, but in a matter of 1 week or 2 weeks, entire hospital was filled with COVID. So in the state of Karnataka, our government took the decision to have isolated COVID hospital with 1,700 beds. And fortunately, today there are only 50 patients, but they were prepared for it. It is very interesting how the governments have woken up and taken the action. And in Karnataka state, in no time, they started fewer clinics across the state. And now we can see the results. In Karnataka state, the number of patients, the COVID patients are coming down dramatically. Now, who's going to be the winner at the end of 1 year or 2 years? The winner is going to be the state which is going to do the maximum number of tests and isolate the positive patients, and a state which will not go for an outright lockdown of the whole state, but identify only the small pockets of what we call as a micro hotspot, contain that space, because this kind of a micro hotspot and micro lockdown will be required in every part of the country for the next 1 year at least. So in the end, my observation is that Today, states are trying to hide the number of COVID positive patients by doing less number of tests. This is going to be extremely detrimental for the security of the people and the country. States should come forward and do as many tests as possible. When you do the test, positive patients will be identified, they can be quarantined, and more than anything else, I want all the states to know that in the end, at the end of 1 year or 2 years, their performance is not judged by the number of patients who became positive. Their performance is judged by the number of people who died following COVID. Now, if they want to show better results, just by manipulating the data statistics, they should do as many tests as possible. As they identify more positive patients, statistically, their mortality will goes down without doing anything else, without even taking care of the patient, just by the sheer number. So never try to hide your the positive patients. Try to do as many tests as possible. Every district must have at least 10 to 20 testing centers. Everyone should have the freedom to get the test done if they wish to. So that is the best way to manage this crisis in the long term. Now, what is the opportunity for India? The opportunity for India is that this kind of epidemic is not the last time. So when we plan what is our future, we should not look at what is the requirement of manpower, doctors, nurses, technicians for a country like India. We should look at what is the requirement of doctors, nurses, medical technicians for the whole world. Today, wherever there is a natural catastrophe, pandemic, flood, tsunami, you see the Cuban doctors everywhere in every country. Why it should be Cuban doctors? Why it can't be Indian doctors? Why it can't be Indian doctors, nurses in other countries when they are in trouble? Cuba, with a tiny, tiny population, is protecting all of the half the continents. Why can't we be the protector of the world? Why can't we be the providers of PPE for the whole world? Why can't we be the providers of ventilator and medical equipment for the whole world? So there is a great, great opportunity, and I have just finished my 15 minutes, and I'm extremely grateful to you for the opportunity.
Thank you very much, Dr. Devi Shetty, for those very illuminating remarks. And when we proceed to the Q&A part, I'm sure you will also reflect on whether or not, taking from what you've said, whether or not many of our youth can actually be trained in vocational schools for a limited amount of skills that an anesthesiologist is required to have, only for the purpose of operating ventilators, and not to have full spectrum knowledge, because that would be far more expensive. That, of course, will mean where do we get all the ventilators from? Do we have a ventilator for each potential patient in the future? And if we are to make our own profile similar to that of Cuba, of course, it will call for all-out action by the government in terms of creating medical institutions. I'm sure you'll reflect on this in due course. I now turn over to our next speaker, Dr. Alexander Thomas. You have 15 minutes, Doctor. Please go ahead.
Webinar. So I will basically try and address two areas, that is protecting of health workers and the exit strategy. Now, has the lockdown been beneficial? I think Devi has spoken at length about it. But scientifically also, there has been a slowing down of the pandemic through if you can look at the growth rate of active cases, and also the chain of the transmission has reduced. More importantly, during this lockdown, we've been able to get into a state. Almost 600 hospitals across the country have now been designated COVID hospitals and ready to accept patients. Some of them do have patients. They have about close to 12,000 ICU beds. Now, the other parameters, we are talking about testing, and we're not very sure whether testing is an indicator, but there's something called the disease surveillance program in the country, and they monitor the flu-like illnesses in the country, and they have reported that they have not seen a spurt in that. Number two, hospitals have not seen an overloading of patients. Testing with regard to testing, even if you consider the present figures, the testing positivity rate is about 4.4%, far better than the US, which is 19.3%, and Spain, which is more than 18%. Of course, India has its advantages. We are the country with the largest group of younger population. 90% of the Indian population is below the age of 60. And we also have a very large rural population. I think these two factors are very important. And of course, they are the other gray areas which the world is talking about: the BCG vaccine, polio, the presence of malaria in our population. Now, with regard to protecting our frontline warriors, I would also call them warriors. I think it's important, as Ambassador said, that the frontline warriors should be treated as soldiers going to war. They should be armed well. They should have the full backing of the community. They should be supported by the government. Unfortunately, what has happened over the last few weeks is absolutely terrible and unfortunate. I think we must realize, the community must realize, that the health warriors, ASHA workers, nurses, doctors, paramedics, it's a tremendous selfless service, and each of them is risking their own lives and risking the lives of their families. I think this whole stigma, it reminds me of the time of HIV and AIDS. And in the last couple of months, we have seen eviction of nursing people from their houses. We've seen attacks on health workers. And I think very, very hurtful and very bad to the morale of the health workers was the hindering of funerals. I think all of us have heard about the two health workers treating COVID patients who got COVID, and then they were not allowed to even have an honorable funeral. Now, the government has done something in this. I think the Prime Minister has assured the medical community, the frontline workers, that country is behind them. They have passed an ordinance recently. Life insurance of 50 lakhs has been announced to both anybody dealing with COVID who loses his or her life, whether it's in the private or public sector. Odisha has gone a step ahead. Any health worker who dies in the line of battle is given a martyr's status, which I think all our soldiers get, and I think it's a very reasonable move, and I hope other states also follow this. But I think we need to try and analyze the problem. What is the issue? I think the first thing is that it was. Can we have how can society protect the warriors? I think in the present scenario, the media is unfortunately helping this fear psychosis, this paranoia, which has seemed to have got hold of the community, saying that millions will die, millions will be affected. But look at the actual facts. The mortality from the countries where have got it before us and which have been predicted is 1.4%. I'm not saying that this has to be ignored, but compare it to the MERS epidemic, 34% mortality, in SARS, 9.6%. So I think we need to present this information to the public. I think this is a time where we need, as a society, to be cohesive rather than being divisive. And the media has a very important part to play in this. And I think it is important that three very important steps: social distancing, hygiene, both personal and community, and masks have been recommended and are the way forward. Now, looking at our frontline warriors, just a few points. I think all of them need to be provided without any limitations. The PPE is required. They need this to be on the front lines. They should have access to testing, but in addition, they need universal precautions and the work environment. We were just mentioning that it's very difficult to work in these suits. You can't work for more than 6 hours. So I think it's important that the environment of the health warriors are really looked into and they're looked after. And there's another point which I'd like to bring to the notice of the viewers: the help of the hospitals. I'm not sure whether many of you are aware. I come from a mission hospital background. I've served my entire life in mission hospitals. And now I work in the secular field. And universally, without any exceptions, I think all the hospitals are facing a financial crunch. Their income has plummeted. They're not able to pay salaries. So I think the government needs to very, very urgently look at this. I know all industries are hurting. I think it's important to know that this is the frontline warriors here, and the health sector is pivotal in fighting and trying to protect the country from this pandemic. Very quickly about the exit strategy. I think it has to be cautious. It has to be differentiated. You can't have one solution for the whole country. It has to be staged. I think most important, it has to be district-wise, because I've read the papers today, and quite a number of districts are free from this pandemic. So it has to be at the district level, the planning for this. We were talking about ventilators in hospital, but I think it's important to remember that only 1 or 2% of the population would require this. The real war is at the district and the primary health centers. My organization, AHPI, has been saying this for a long time, that the public sector hospitals need to be strengthened. If you look at the present scenario, 70% of the healthcare is being provided by the private sector, and only about 30%, and that 30% also, there are a lot of issues like staff, specialist shortages, etc. I think India needs to wake up. We need to strengthen our public sector hospitals like it was about 30 or 40 years ago. Yes, hospitals and ventilators are important, but it is at the PHCs and the district level that we need to actually take action. Contact tracing, either home or community isolation, and health education is the need of the hour. And for this, it is important that our organizations at the grassroots, starting from the PHCs are involved. Now, coming to the exit strategy, I'm going to base my remaining few minutes on the strategy that we were asked to do for the government of Karnataka, which we have submitted. So I think we need to divide our population into 4 groups. The group A, which is not infected; the group B, which is probably infected, asymptomatic or mildly symptomatic; group C, which is infected with a severe illness; and group D, I think a very important group, which I think we have forgotten in this pandemic, the persons with the non-COVID conditions. Now, very broad guidelines for all these 4 groups and for the states, that in the early stages, rigorous isolation, contact tracing, and quarantine at home if possible, if not community isolation centers. And COVID-19 hospital care should be reserved only for severe infections. Non-COVID conditions should receive equal importance, which is not happening now. And health services should continue provision for these services for all groups for such conditions. The government of India has made it very clear that there should be no mix-up of COVID and non-COVID patients, learning from the experience in Italy, where 40% of the patients were infected because there the COVID patients were mixed up with the non-COVID. Teleconsultation should be encouraged, and I'm glad that I think Devi and AHPI have been fighting for this for a long time, 3 years. One good thing which has happened now is teleconsultation is now legal, and it should be encouraged. There is a huge mental stress aspect which has to be taken care of, and we have recommended to the government that there should be a helpline exclusively for mental health issues. And I think another aspect which allopathic people are not very keen on, but I think is important, that we need to improve the immune status of the population and of the patients by incorporating the Ayush recommendations, Government of India Ayush. Now, coming to the group A, which is not infected, the continuation of physical distance is very important. Wearing of mask is important. Basic hand and surface hygiene, respiratory etiquette, avoidance of social gatherings and crowds, and again repeating that Ayush prevention guidelines as per Government of India should be followed. Coming to group B, probably infected or mildly symptomatic or not symptomatic, home isolation for mild symptoms, home quarantine for the family, community isolation where this is not possible, and again use Ayush recommendations. The group C, the infected and those with a severe illness, I think here the health authority should be immediately informed and this patient should be admitted in COVID-19 hospital. Coming to the other important group, which I'm laying a lot of stress on, is persons with non-COVID conditions. Unfortunately, this is a group we have missed, and I have personally heard of at least 3 or 4 patients who have died because they could not access care. So it is important that continued care is available for them in the outpatients, etc. There should be measures to reduce, to avoid crowding. There should be segregation of patients into different groups. Appointment systems should come into play. Strict maintenance of prevention protocols by the providers at all levels. And of course, I think telemedicine would be, and use of technology would be very important. I think I'll stop with this, and I must say that I feel that the government of India has done a great job, a good job thus far. We have been recognized by WHO and other nations, and I'm sure that, as the Prime Minister said, every one of us should contribute, and together as a nation we shall overcome. Thank you very much.
Thank you very much, Dr. Alexander Thomas, for your remarks. Very interesting, and I think we leave you in no doubt that all of us agree with what you said about this challenge and this war on the pandemic being the responsibility of entire societies, and that the protection of healthcare workers should be uppermost. We should do all we can to provide them the wherewithal to keep up this fight. I was a bit intrigued about what you said, the differentiated, exit strategy at every level, and this is something that we will obviously try to raise again during question hour. I will now move on to the third speaker, that is Dr. Harish Pillai. 15 minutes, please.
Thank you, Ambassador Chinoy and the Manohar Parrikar Institute of Defense Studies. When I first got this invitation from Colonel DPK Pillai, I was quite fascinated that the think tank involved in strategic affairs is also interested in healthcare. And of course, the answer is so simple that health is also a key component of national security. The other day, I was listening to Hard Talk in BBC, where the presenter, Stephen, was asking the NATO Secretary General on what is the impact of COVID on the NATO forces. And it's very interesting how the security establishment also need to really look at it from a very different kind of a paradigm. Now, coming to what I would like to talk about is the questions which the previous speakers also talked about, that how do we increase capacity in our country in terms of early predictions. And Ambassador, you're absolutely right that the whole debate whether this pandemic is a black swan event, you said it, that we all knew that it was just a matter of time before this respiratory virus struck us, and astonishing that how unprepared the rest of the world was in handling this thing. So some cues which I would like to talk about is we have that intrinsic ability, and the most fascinating phenomena in the Indian subcontinent is the monsoon. And if you look at IMD, the Indian Meteorological Department, we have that power of quantum computing in terms of predicting both short-term and long-term ranges of how the monsoon is going to behave. When some event happens in the central equatorial region in the Pacific Ocean, the El Nino phenomena, many of us who are avid monsoon watchers, we closely look at what's going to happen to the southwest monsoon in India. So it's in the same context when we talk about diseases. When we look at any sort of pandemics, there are focal points based on socio-economic paradigm, cultural habits, because in this specific pandemic, you already said that there's a hot debate happening around the world whether is this something manufactured in a laboratory, or is it truly an example of a zoonotic transmission from animal to human. So that debate is still not settled, but it's there. There are 2 points of view. Having said that, we need to have that ability within our country to constantly peer from a strategic point of view, because clearly a country of our size and the stage of economic development, we just can't take similar kind of blows on our chin, because it just breaks down the entire equations for progress. and we have to now start from scratch. Looking at some examples from around the world, it's quite fascinating that if you look at a AI-based company from Toronto called Blue Dot, they were able to predict this outbreak on 31st of December, which is a good 9 days before the Chinese authorities or even the WHO had announced that such an event is happening in China. And how did Blue Dot make such an announcement on December 31st? Was basically leveraging the power of artificial intelligence, machine learning, neural networks, and it just kept on. Their algorithm kept scanning on what's happening in terms of demographic trends. They looked at ticketing trends and predicted that within a matter of time, this virus is going to spread in these locations in China and also in neighboring countries. Around the same time, another AI firm which is based in San Francisco called Metabiota, that looked at social media feeds and also looked at an algorithm looking at linguistic neural programming to predict the spread of this virus in countries such as Japan, Taiwan, Korea, and Thailand much before a single case could happen. So that technology already exists in the world, and this is the first time in human history where we were able to predict so fast where this disease is going to spread. So that is something phenomenal in terms of the technical ability which mankind possess. Moving away from this aspect, okay, we know that the pandemic is spreading like wildfire across the globe. We also could make out the example of a company called In Silico Medicine, which is based in Rockville, Maryland. It's part of the Johns Hopkins Institute for Innovation. They had a powerful algorithm which scanned thousands of molecules which are already existing, and they mapped these molecules with the genetic structure of this COVID-19 virus to look at that within this armamentarium of drugs available, which could be the most effective one. And all this was done within 4 days. And it really helped to equip the frontline troops, healthcare workers around the world to let them figure out that among the large amount of molecules available, these set of subsets of molecules will be more effective. Another point which both Dr. Shetty and Alex also mentioned is about these candidate vaccines. We know about prospective candidate vaccines around the world, but if you look at the history of speed in discovering a new vaccine, this current pandemic is going to shatter most of the world records. The speed in which candidate vaccines have been produced is primarily because of the ability of artificial intelligence, cloud computing, and of course manufacturing ability. The first of the block was Flinders University from Australia, where they figured out a specific algorithm to produce a candidate vaccine and moved on to animal trials followed by human trials in the United States. So many of us around the world, we feel that one of these vaccines is going to prove very successful quite sooner than later. Something else which was interesting from a headline point of view, news headline point of view, was this is the first time when competitors forgot about rivalry and sat down together on the same common platform to talk with the WHO. I'm referring to Apple, Google, and Facebook, where they discussed with the WHO the ability of an interoperable API, which can access common public health apps that can be downloaded both from Google stores as well as from the Apple stores, and it's going to be launched in the month of May. So this is also something interesting where these kind of tech giants can come together to improve the cause of public health. We already have examples of Fitbits around the world, whether it could be your iWatch or other devices which can constantly monitor your sleeping pattern, your basal heart rate, and over a large demographic population, figure out in terms of pattern of behavior, which could be also an early reconnaissance sign of an emerging disease pattern. It need not be a pandemic, it could also be a epidemic. There is also an interesting example of a smart thermometer produced by a company called Kinsa. So this smart thermometer can connect to your smartphone using a Bluetooth and record temperatures and put it to a central server. So based on the number of smart thermometers available in the public foreign, public health experts and epidemiologists can show a fever pattern which is emerging across a large part of the world, or even for that matter a country. Like the previous speakers spoke about, thanks to 24 by 7 news channels and also social media, there has been a lot of fear mongering
I'm busy
taking
right
place
now. I'm not
in the
chairing a meeting.
in the common man. And many of us in our hospitals, we have been faced with floods of calls to the point that our telephone exchanges were almost jammed. Nobody could get through. And these were the early days in Feb when many of us thought about introducing AI-based chatbots. In many leading hospitals in India, you have these AI-based chatbots were introduced where anyone can just go and look at, fill up a few basic questions, and the chatbot is able to answer most of the frequently asked questions, leaving the healthcare workers free to focus on their critical aspects. Also, I mean, we don't have, like Dr. Shetty mentioned, thankfully, mercifully, in our country, we don't have the at least at this point of time, our hospitals are not facing the surge of patients. But one key diagnostic tool within a hospital in an acute care setup is use of CT scanners. My network, we run a group of hospitals in the city of Dubai, which unfortunately has got a large amount of COVID positive patients. And my hospitals, including the public hospitals, are totally overwhelmed with COVID positive cases in different stages, including on ventilators and in ICUs. And what our clinical team from my own hospital says that the role of a CT scanner in early detection of the classical pattern which you see in a CT scanner, by which you can say that this is indeed a COVID case and you need to take appropriate measures. Now, for a good trained radiologist, it might take up to 6 minutes to come to a effective diagnosis. But now you have an AI tool which can do the same thing in 20 seconds, cutting down the speed and improving the efficiency of managing these cases within a hospital setup. Moving away from a hospital, when we look at the example of what happened in Wuhan, the effectiveness of the lockdowns, which the Chinese authorities were able to do. Now, you must also recognize that China has got one of the most densely populated regions for CCTV cameras, which are embedded with face recognition softwares. And it could be a draconian measure from a security point of view, but for managing this COVID and effectiveness of lockdown, they did use facial recognition technology and CCTV cameras to ensure that the region specific lockdown is very, very effective, especially in Wuhan. Another example what China has used is the use of drones, which has got cameras and also infrared sensors which will pick up the skin surface temperature of anyone walking down the street to say that X person has got a higher surface temperature than Y, and hence through a public address system, the drones could tell that person to go into either a government managed center or go into quarantine. We also have examples of Chinese drones spraying disinfectants in areas where the authorities could not reach on time. The same examples of drones have been used in different states in India effectively. In terms of in the early phase of a lockdown, we found that many states the authorities had a challenge in enforcing the lockdown in India, and India also has effectively used these drones for in terms of enforcing the lockdown. The other good example also from our country is the Arogya Setu, which has got millions of downloads. I'm told it's more than a large amount. I'm told more than 10, I think more than 15, 20 million downloads have taken place. This is a very good example for contact tracing. You can imagine in the old days when such an app was not available, you had public health workers or ASHA workers going from house to house to do these kind of tracing, which is humanly impossible in the middle of a pandemic. Now, Arogya Setu also answers questions in all vernacular languages in India, and also is an effective tool to do contact tracing. And it's connected to a central server, which also gives you a large pattern of where these cases are happening. Coming into the last point, which Dr. Devi Shetty mentioned, very, very critical in terms of learning from the lessons of pandemic, of focusing on Make in India. When the Prime Minister's, the clarion call of Make in India, it involves the entire spectrum. And I truly believe as a citizen of this country that our greatest strength is our people. And we have that intellectual capacity resting in all our major labs, whether it is CSIR, with the Indian Space Research Organization, with the DRDO, with the Indian Institute of Science, the IITs. if we can go on a mission mode and look at all tools which are required to tackle this pandemic, whether we talk about the shortage of diagnostic kits, and it took a lot of time for us, and that is still a challenge for us, that we just are not producing enough diagnostic kits in India to meet the demand. So on a mission mode, I guess we will have to look at the entire spectrum, whether it's diagnostic kits, ventilators, PPEs, and also like the National Disaster Management Authority, which is well equipped, and we have a strategic resource available to look at natural calamities. I think it's time that India also builds a natural resource to handle epidemics and also pandemics. These are the most important lessons which I see from this specific thing. Uh, of course, it's well known around the world that India is truly the pharmacy of the world, and it took someone like President Trump from United States to call up Prime Minister Modi to tell that we need to ease up the ban on exports of the dihydroxychloroquine. It was basically I would say it was India's moment in the middle of this pandemic, because so many countries around the world were depending on Indian pharmaceutical ability to supply drugs for the sake of those countries. So it's also not just a moment of pride, but I feel that it's a moment of reckoning, that what skill sets and infrastructure we have built in the pharmaceutical industry, we can easily leverage our technology base, the institutions which I mentioned before, plus Bengaluru is known as the Silicon Valley of the world. We have so much of software ability residing in our own country, and we need to leverage that and provide these kind of solutions to the rest of the world much before the next pandemic arises. So that's what I have to say. Thank you.
Thank you very much. Can you hear me?
Yes, sir, you are audible.
Yes, I somehow kind of got cut off temporarily, and I'm back. You can see me now. Thank you very much for those very, very helpful remarks. Dr. Pillai, you actually spoke about the technology aspects. I'm hearing an echo of my own voice, so I'm not quite sure what's happening. Is it clear? Can you hear me?
Yes, sir, go ahead.
Well, something's happened, but anyhow, you can both see me and hear me. And you're not presumably getting an echo. All right. So now we'll move over to the Q&A side. But I do want to kind of look at how AI could be misused in this regard, because if you have firms like Blue Dot, as you said, working on all kinds of algorithms based on data, and in a world in which there is so much of motivated data going around, what prevents malicious and malevolent forces from releasing data that point in wrong directions, simply to kind of cause harm to large numbers of people? Will hazmat suits become part of personal kits in years to come? How are we going to really defend ourselves against the next scourge when it comes? Because the vaccine that you develop may be good enough only for one particular kind of coronavirus. And if it is mutated or there are many other versions, it's a matter of guesswork as to how effective these would be. So this is something that we might like to keep in mind. I personally had a question, and I want to begin with that. And it is to do with the Hippocratic Oath that you take as doctors. When you juxtapose that on a moral plane with the fundamental right of every individual to health, and in the Indian Constitution, it is a fundamental right. How do you then condone doctors pulling the plug from elderly people to enable young people to survive? I mean, that's a gray area. Human beings are human beings, and lives are all equally precious. So at what point do you decide that it's not worth keeping an elderly person alive and it's better to give it to so and so? I mean, I think that's a moral dilemma. We have General Menon from Bangalore who has asked a question It's directed at Dr. Shetty. Considering the enormous scientific uncertainty about COVID-19, what is the basis on which you made that assertion that there was a 50% mortality saving through the lockdown? There's another question. This is by Dr. Vinod Kumar. Dr. Vinod Kumar asks, considering that it was mentioned that there could be a bottom-up approach in terms of highlighting hotspots and containing them, then perhaps was there any merit in having a nationwide lockdown? If that is the exit strategy, then could we not have begun with hotspots and a bottom-up approach in the first place? We also have, well, several questions here, but I'm actually signed out of my first session. I don't know why. Vinod had another question. I would leave it to him to ask that question in due course if he wishes to. There's one more question. Whenever schools do open up, be it in July or October or next January, will there be anxiety and apprehension on the part of parents and children? Is hybrid learning model of the future? Or is there a possibility also of having health passports, some kind of credit system that you wear like a badge on your chest, that, you know, I'm healthy, free of coronavirus? There's news about pollutants carrying coronavirus. So any further precautions that can be taken? That is a two-part question that came from Kanak Gupta. Then we have Deepa Singh, who has, contrary to my expectation, written a very large question. Anyway, the question is addressed to either Dr. Shetty or to Dr. Thomas. How can agricultural innovations help the medical field to fight the pandemic, not only for COVID-19, but also for future pandemic outbreaks? Can these agricultural innovations help the rural population, especially in the short run, to fight COVID-19? Any examples? And to Dr. Pillai, Kanak Gupta asks, are there any new industries emerging with domestic manufacturing of PPEs and ventilators? There is an opportunity for Indian industry to export the PPEs or ventilators, but do we have the capacity to first be self-reliant for our own potential patients? So there are these several questions. In fact, one more. Jatin Kumar to Dr. Shetty, please explain the concept of herd immunity. Major General Sandhu asks, how different is the strain in India from the strain in Wuhan? Well, generally speaking, I think I've covered most of the questions that were asked, and I would now request each of the three speakers to take the floor again and to reflect on either what was said by fellow panelists or these numerous reactions that have come from among the audience. Over to Dr. Devi Shetty first.
Thank you. Thank you so much. It's about my guess that mortality would have come down by 50%. It's not based on any of the scientific data. It's based on our assumption of how assumptions based on the fact that the virus will behave exactly like how it behaved in Italy and in US, and patients will behave exactly how they behaved in Italy and US. We have to just assume that we are like anybody else, because it's always better to err on the wrong side rather than trying to be optimistic and not being prepared. I'll give our personal commitment to this assumption of a pandemic really hurting the country. We as a group invested over 10 crore rupees in a matter of 1.5 months to build a 70-bed ICU only for COVID patients. We changed the whole building and put 70 ventilators, all the oxygen suction lines and everything, 24 hours people work. huge investment. Then we worked with the Infosys. We virtually chased away guests from a hotel next door in our health city and converted it like a quarantine facility for asymptomatic COVID patients, assuming that public hospital will be overwhelmed and the COVID patient will come in a desperate situation to us. By the grace of God, our COVID ICU with 75 beds with all the equipment till date hasn't seen a single patient. And our 100-bed hotel for a quarantine facility hasn't seen a single patient so far. So would you like to call it as a miracle? I would call it as a miracle because with no stretch of imagination, a city like Bangalore, you see the highest number of the COVID patient you see in cities where there is an international airport, because that's where the infection starts happening. Across the world, that is a common phenomenon. So looking at the way the numbers are today, it is dramatically different than what we anticipated. This is the basis of assumption that mortality would have come down by 50%. Maybe it is more or maybe it is less, but it is nothing like what we ever thought it would be. Now, in terms of impact of COVID on education, believe me, country will never be the same after the COVID-19. This world will be a dramatically different place after COVID-19. The transition is exactly like during the Second World War. Till that time, American women, European women never went out for work. When all the men went out for work, women had to come out and work. They started working in factories, they started working in offices, in defense research, and everywhere. But when the men came back, they continued to work. And that has been a major transformative impact on the society and the structure of the society. Now, education forever will undergo dramatic change. Because of the online education, healthcare will be dramatically changed with online healthcare. Now, about herd immunity, this is a very dangerous track for any policymakers to follow in the beginning of the epidemic without really understanding what is the impact. Traditionally, epidemiologists will always say that these kind of viral epidemics, only way you will be able to solve is by waiting for the herd immunity. That was okay when the spread of virus is slow and it doesn't overwhelm the healthcare system. First time in the known history of the society, the overwhelming of the health system was so much that the doctors are pushed to decide on who should be saved and who should be allowed to die. So, waiting for the herd epidemic to happen, like what it happened with the bureaucracy and the political decision taken by the British government, waiting for the herd immunity, and you can imagine what is happening there right now. This is the situation, because for the people to develop herd immunity, at least 50% of the country's population should be covered, should be infected with the virus. And that has a disastrous consequence, especially in European countries, where their average age is much more than Indians. So on the whole, this 3 months, we learned a lot more than we learned in our whole lifetime. And the future is dramatically different. And healthcare will dramatically be different, because I'll just give you one example before I finish. The mortality in Italy is extremely high. Mortality in Germany is very, very low. How this happened? It may happen mainly because in Italy, in Germany, they have 29 ICU beds for 1 lakh population. They have the highest number of beds, 29 ICU beds. Whereas in Italy, they have 12 ICU beds for 1 lakh population. In England, they have 7 ICU beds for 1 lakh population. In India, we have perhaps 1 or 2 beds for 1 lakh population. Thank you.
Thank you very much. Dr. Shetty. I now turn to Dr. Alexander Thomas. And before I do that, I will read out one more question that's come in, a couple of them, in fact. One from Dr. Vinod Kumar, one more from him. And he says, if the Oxford group succeeds in coming up with a successful vaccine, should Gilead, is that how it's pronounced? Should Gilead's commercial global sale of remdesivir be encouraged? Considering COVID's reach, shouldn't the generic availability of vaccines be prioritized by the global public health community instead of allowing pharma majors to engage in commercial exploitation as and when the vaccines are readily available? And there's one more by Dr. Uday Bhanu Singh. I'm trying to locate it as quickly as I can. And that one, if I miss it, Uday, please forgive me. It's just too much here. I think it was something to do with agriculture. It says, can India's food security be affected if our agricultural sector were to take the brunt of the pandemic at some stage? Of course, the answer would border on the very much yes. But let the doctors, good doctors, come forth and tell you how bad it can get. I tend to agree with Dr. Shetty when he said that the lockdown, of course, helped save a very large number of lives. Imagine what would have happened if we didn't have the lockdown. But anyway, that's only an opinion that I have. He, of course, has said it with much more proof at his disposal. Dr. Alexander Thomas, please.
Yeah, thank you. I think the last question first. I think it is very crucial that we get a vaccine, and I think our efforts should be focused on getting a vaccine. But I think that's going to take at least a couple of months. So for this drug that you mentioned from Gilead, it is for treatment of sick patients. So I think it should be done parallelly. Focus should be on vaccines to save maximum lives. Talking about the Hippocratic Oath, I think you touched on a very relevant point. And I think this happened only in Italy. And it happened when I think the situation became, what should I say? I can't find the, it became horrible. And I think many older people were volunteering, saying, I don't need a ventilator. It would be better if you save somebody younger. So having said that, we are not the persons to make the decision. We will not make the decision, but I think these were very extraordinary situations in Italy, and I'm not sure how it happened, but it happened. But the Hippocratic Oath, and I'd like to reiterate as medical professionals, our commitment is to save every life, and that is why we are seeing, even today, as I mentioned earlier, that not only the doctors, even the other medical professionals are risking lives with the family to ensure that we look after our patients. Now, coming to the mortality, I think, wholeheartedly agree with Devi. My guess is probably more than 50% mortality that you saved. And apart from it, we don't have much data. We really don't know this is a new virus. But the limited figures which I had mentioned in the beginning of my talk, in India, as I said, there is something called a disease surveillance program where each state reports. So they certainly have not reported a wave of flu-like illnesses, which the test may not have picked up. Hospitals are not overcrowded. And if you compare our country with other countries where the virus entered at the same time, where lockdowns were not as strict or not carried out, I think there's a veil of a difference. And my guess is that we have saved, the mortality has actually probably come down to probably a quarter of what it would have been otherwise. So you had asked also about would it now be that all doctors and medical personnel wear hazmat suits? I think medicine, like all other areas, is going to be a new normal. They have to take universal.
We lost your sound there.
Yeah, yes, we got a call. We were talking about. Can you hear me now?
Yes.
We were talking about the HIV pandemic. Something similar happened, and then the concept of universal precautions came into being for all health workers. I think now with this COVID, there's going to be a new normal, and universal precautions have to be taken. Universal precautions have to be taken by all medical professionals. Now, there's one question I cannot answer, and there is agricultural innovation. I can only put it this way, that agriculture is related to health in the way that health is related to nutrition. So yes, I'm sure agricultural innovation is required. I can't think of anything right now, but yes, agricultural innovation, like many other innovations in various other sectors, will supplement the health of the nation by in various factors, by improving nutrition, by improving immunity, etc. What are the other? Yes, I think those were the questions which I noted down. Ambassador?
Yeah, thank you. So I will now turn to Dr. Harish Pillai, but before I do that, a couple of more questions. Feel free, whoever wishes to answer it. One more from General Menon, who's asking, what is the advice the PM can receive from the likes of you in regard to the lockdown that is slated to end on the 3rd of May? What would you tell him? And then Deepak Haridas, general question. Many hospitals are quarantined because they were not cautious enough while treating COVID positive patients. And shouldn't the hospitals be doing something to train their staff even more rigorously and to put better guidelines in place? Because if you have doctors, nurses, and healthcare workers going out of action, that really means you have less people to fight the war against the pandemic. Dr. Harish Pillai, and of course the other two can step in immediately thereafter. It's our desire to intention to end this meeting at 5 p.m. because at 5:15 we will switch to an entirely different subject like defense procurement procedures, and that's a different world of budgets and armaments and stuff like that. And that is in tandem with the US-India Business Council, with about 40 American companies also participating. Dr. Harish Pillai, you have the floor.
Yeah, thank you, Ambassador Chinoy. So I'll take the last question first. What advice would three of us give to the Prime Minister with regards to the lockdown? And that has been eloquently answered by Dr. Devi Shetty in his opening remarks. We have largely succeeded as a country to slow down transmission, and it's all the data what we have at hand proves that. Having said that, we still have disease clusters in metros such as Mumbai, Pune, Hyderabad. We have issues in Delhi. We have some states, districts, which has been identified as red zones. So in those areas, the lockdown has to be more stringent and continued, I suppose, till the end of May. So it would be a very calibrated approach, where in some areas where you have these disease hotspots, it will be much more tougher than before. Whereas in the rest of the country, especially in the green zones, those districts we can ease off the restrictions with those behavioral changes which Dr. Alexander mentioned. That you need to still practice social distancing, you need to wear your mask. So all those behavioral aspects will be a part of the new normal till such time the vaccine comes about. So that's the first question. The second question is with regards to hospitals being quarantined because some of the staff got infected. It's an unfortunate fact that many hospitals, both the public and private sector, did not follow protocols as is required in the midst of any epidemic or a pandemic. Just to give you an examples of what many organizations in India have already done, one was to establish a command center which will centrally look at protocols and guidelines, including manpower deployment. Now, the first thing, even before the lockdowns were announced, was to look at who are your non-essential staff, and the non-essential staff need not really come and degrade your ability to manage the situation. So they were all requested to stay at home, and of course, the lockdown reinforced that. You looked at your own your rosters, your manpower rosters, and looked at your critical resources. The critical manpower resources to manage a pandemic are those who will man your fever clinic, your emergency department, your critical care teams, internists, pulmonologists, and infectious diseases personnel. So these are your frontline crack troops to fight this battle for COVID-19. So you ensured that the manning rota is such that one third are deployed in the hot zones, whereas 2/3 is kept off-site. And in fact, 1/3 of that would be in home quarantine so that they can relieve your exhausted troops from frontline battle scenes. So this is something very important. Another soft spot which many hospitals in India did not recognize was the accommodation, where the staff, like you talk about the army barracks. Similar to that in healthcare, the frontline troops, especially nurses and paramedical staff, usually stays in shared accommodation. So many of us took an effort to ensure that no one stays in a shared dormitory. In fact, the frontline troops were asked to stay within the hospital premises in a kind of a cohorting arrangement. So this simple measure ensured that there will be no possibility of transmission within the hostels. And unfortunately, many hospitals in India ignored this basic principle, and they have this challenge. The other important defense in terms of looking after your healthcare workers is to ensure there is no mixing of staff. People who are in segregated, dedicated zones for COVID cases, those staff are not deployed for taking care of non-COVID cases. So this strict segregation of staff and zoning of where these COVID patients are kept, that was a very important decision in terms of a natural defense against transmission within a hospital. Some of us also looked at, especially with the Indian Council of Medical Research, ICMR, when they came out with their guidelines of dihydroxychloroquine, based on a voluntary consent by the healthcare workers. Many of us also looked at of issuing dihydroxychloroquine as a prophylactic measure for healthcare workers. But I think over and above, the most important aspect is the ramp up of your PPE inventory. And if you really study the root cause analysis of why did some of these hospitals unfortunately went into a lockdown, is because they did not have adequate PPE. And there is one more dimension, which is the human side. It's not just the availability of PPEs, but also the technique of wearing the PPEs and doffing the PPE. So we know from case studies around the world that one vulnerable time when healthcare workers get infected is when they start removing their headgear, the mask and the gloves. Unfortunately, they get contaminated if there is no close supervision or proper technique. So that's what we call as wearing your PPEs and doffing the PPEs is an important aspect of protecting your staff. So this is the second question which came to me. The third question is in terms of manufacturing ability. It is true that right now, in terms of ranging from diagnostic kits to ventilators to basic PPEs, domestic capacity is slowly ramping up. We have not reached the stage of self-sufficiency where we can cater to the rest of the world like pharma sector. It will take much more time, I would say a couple of years, for us to reach that ability for us to export to rest of the world. But it has already shown us the popular Indian term of jugaad, where Indian ingenuity in terms of frugal innovation is brought into picture, where we have been able to knock down the cost of most of these things, which otherwise it's so expensive to import.
And even rich countries, Dr. Pillai, are having a tough time. I mean, we are hearing of old raincoats being pulled out, unused ones in Japan. Who would have thought that Japan would see a day when it has to use unused, old, yet new kind of raincoats to fight the COVID-19? So, I mean, there's much greater challenge at our end.
So I guess I would have answered most of the questions addressed to me. Thank you.
You have. Thank you very much. We have a couple of 2 minutes more, so I would like to give a minute each to Dr. Shetty and to Dr. Thomas in case they wish to add a few words. Dr. Shetty?
Observation is that we should not, henceforth, we should not look at India as one entity. We should look at India as Europe, where every state is like an independent country. Now you will start seeing huge difference between the number of cases and the outcome and the results of whatever they are doing. It will show up very, very clearly. So it is very important that when we present the data of the country, we should not come up with one data. We should show every state separately. That will induce a healthy competition, and we should be competing with each other, not on the number of cases which patients will become positive, but on the number of tests we perform. Unfortunately, few states are very reluctant to do a rollout large-scale testing facility with the fear that more cases will be diagnosed. And that is going to make a huge difference between the outcome of whatever you're doing, because in the end, states and the countries will be judged not by the number of positive patients, but by the number of patients who are dead.
Thank you. But that also suggests that we cannot really take an ostrich-like approach to this, and states cannot afford to do that either. And particularly when we are all aware that there are millions, the large majority actually is to be found in the rural areas. And so it's incumbent on them to go there and test as quickly as possible. And I therefore favor the kind of approach that you are suggesting. Any last word on this, Dr. Thomas?
Loud and clear that India needs to be self-reliant in many areas. And again, I reiterate what I said earlier. I think the public health system in our country needs to be strengthened, and strengthened greatly.
Thank you very much. Now, I want to end by actually just recalling something incidentally that Dr. Harish Pillai just mentioned about crack troops. And now you all know what crack troops means. It's not about the ones with the tanks and the guns and the airplanes and the ships, but it's really our healthcare workers. And there is no doubt that today, as we face this great pandemic, we actually owe our well-being and our lives to the healthcare workers, to the doctors, to the nurses, and to all the other thousands of people who are silently and often anonymously working long hours behind hazmat suits, behind masks, such that we do not even put a name or a gender to these selfless warriors that are doing their best for all of us. And I would therefore like to end by reading out a famous epitaph that is in the war cemetery in Kohima, where there is a commemoration of the Battle of Kohima, April 1944, and it reads, "When you go home, tell them of us and say, for your tomorrow, we gave our today." End quote. This, I think, very aptly fits the crack troops of the healthcare sector. We salute you, all three of you, sir, and we wish you good health and personal well-being at all times. And with our warmest and fondest regards to each one of you, I thank you for your contributions. I thank the participants for their contributions as well. Thank you. Good evening.
Thank you. Thank you.